All right, welcome everybody to our special gathering, our special health event focused on telemedicine. My name is Kate McGrail, and I'm the program manager with the Community Health and Wellness Division at Suburban Hospital. While telemedicine is not a new healthcare delivery platform, 2020 has seen a drastic increase in the utilization, primarily due to the physical limitations inflicted on us due to the coronavirus pandemic. But these last few months have allowed the promise of technology to shine. We are now more connected than ever. For one, geography is much less of a barrier, which is why today is a very special day. For the first time in Suburban Community Seminar history, we have a panel of the finest Johns Hopkins providers from Bethesda, Baltimore, and Washington, D.C., speaking at the same time. And you, some of our participants, are joining not just from Maryland, Virginia, and D.C., but we have participants from Massachusetts, Michigan, Illinois, North Carolina, Peru, and Indonesia. So welcome, everybody. With these benefits come some challenges. Many individuals have been nudged or even pushed towards a deeper and more frequent interaction with technology than they were used to or ready for. When it comes to your health, we want to make sure that the access to healthcare does not diminish due to these changes. We are here today to address these concerns, starting with some level setting of the telemedicine platform, how telemedicine is changing the way healthcare is delivered, and some practical applications, including a live video visit demonstration. We will close out our time together with some questions and answers and bring you closer to an understanding of the future of telemedicine for healthcare delivery. You have entered this webinar in a view and listen only mode, which means you will not be able to share your camera or take yourself off mute. If you have a technology issue, we recommend referring to the Zoom help desk link in your welcome email or using the chat feature at the bottom of your screen. We will take questions using the Q&A feature also at the bottom of the screen, and we'll share them with the panelists at the end of the event. A short evaluation will pop up automatically at the end of this event, and we kindly ask that you spend just a few moments to complete it to help us with our continuous improvement for these growing virtual communities. And because we have a lot of content for you today, I'll turn it right over to Rebecca, but you can refer to the most full panelist bios in that welcome email as well. And I have one quick poll for you today. And I'd like to see, just so we all know who's with us, who has used telemedicine in the past 6 months, so since about March. Awesome. All right, so it sounds like a few more seconds. Great. Most of you today have used this platform before, so that's great. So now, Rebecca, right back to you.
Hello, everyone. I'm Rebecca Canino. I'm the Administrative Director for the Office of Telemedicine, and I'm so pleased to be with you here today. Look at those poll results. 88% of you have used telemedicine, and so this is a very informed audience, so we will tailor our presentation for that. All right, so I think one of the best places to start with telemedicine is what is it exactly? So back in 2007, the World Health Organization looked at what the definition is, and they found, I think, 107 peer-reviewed definitions. And there are even more than that right now, and no one can quite agree. This is an emerging science. It's happening. It's changing every day. Each one of your states and your countries have a different definition of telemedicine. So we're just going to say it's healing at a distance. When you talk about telemedicine, you'll hear the words like digital health, mHealth, telehealth. These are all basically synonymous. There's some shades of meaning, except when you think of it, just think of it being able to reach your doctor remotely. So what exactly is it? So there are two basic types of telemedicine. There's telemedicine between your providers, and there's telemedicine between you and your provider. And within those two major categories, there are three types of telemedicine. So the first type of telemedicine is asynchronous. You and your provider aren't talking to each other at the same time. You're not on the telephone at the same time. You're not on video at the same time. That is asynchronous. For synchronous, this is what most people think of when they think of telemedicine. They think they have a video visit with their provider, right? Things are happening at the same time. Now, the third bucket is one that we don't think of, but we use all the time, and this is remote patient monitoring. And this holds both asynchronous and synchronous at the same time. And so this is when your smartwatch is sending your steps to your doctor, so they know how many steps you're doing daily. It's sending your blood pressure to your doctor. And this can be used for chronic disease monitoring, like to manage your diabetes or your asthma or your congestive heart failure or your COPD. And it could also be used for COVID-19. Okay, so under those three buckets, let's talk about some common types of telemedicine. So in asynchronous, an e-visit is probably the most common type. And this is where you would fill out a questionnaire to your doctor. You'd say, oh, I have pink eye. It's been red for this long. It has this much discharge. What should I do? And you send that off to your doctor, and your doctor replies back to you and says, oh, this looks like pink eye. I have sent a prescription to your pharmacy. Go ahead and pick it up. That's an e-visit, right? You didn't have to be in the same, talk to each other at the same time. You could send it off. Your doctor could look at it 20 minutes, 2 hours later, send you the response. You could look at that an hour later and head off to the pharmacy. For synchronous, video visit, right? And so this is a video visit with your primary care provider. This could be a video visit that your child has while they're at school. This could be a video visit with someone in a skilled nursing facility. These are things that are just happening remotely, but at the same time by video. And we already talked about remote patient monitoring, from your biometrics to your chronic care management. Let's go to the next. Now, during COVID, we took these basic types of telemedicine and they got accelerated very quickly in our health system and health systems across the country and across the world. And so some of the things that Hopkins did is that they very quickly spun out Care Companion, which is almost a type of remote patient monitoring. It fits in there, but you were able to put your symptoms in and receive feedback. And then if you were positive, or if the physician wanted to talk to you, that moved over into synchronous, into our cart, where you could call in and a nurse could triage your symptoms. A doctor could order your test, and then they could follow up with you at home to make sure that you were feeling well. And then at that same time, that kind of moves into remote patient monitoring. So your symptoms are coming in, they're calling you a few times a day, you're entering, I'm short of breath more frequently. Maybe they could dispatch home care to actually come to your house and check you out. And then if you needed care, they could facilitate that transfer into a hospital. And so you can really see how telemedicine was used at each step along that journey to take care of you. Now, let's say that you or a loved one did have to go to the hospital during this time or are in there now. Hospitals are using this for virtual rounding, meaning before, when you were in the hospital, every morning, your doctor would come in with your team and they would talk, how are you feeling? They'd look at your lab results, they'd make the plan for the day. Now that all happens virtually with an iPad at your bedside. And so the same amount of people, the same group, that same team approach could be had, but without coming into your room and for lowering your risk of infection. It was also used and is being used now as a way for folks in the inpatient space to be able to reach out to their family and have that support while all the hospitals are in lockdown to reduce infection. You could have that support and that outside contact that's so desperately needed. In our EICUs, there are cameras in there that folks can come in and do some bedside consulting as needed, so we can get your specialist at the bedside as well as the attending that's taking care of you. So lots of advances with telemedicine during COVID. Okay, so how does this apply to us and the folks on this call? So we're not in the hospital, we're at home. What do we use for telemedicine? And so you use your phone, you use your tablet, you can use your smartwatch, Some folks we sent home with pulse oximetry so that you could clip it on your finger and show it to the screen and say, this is my blood oxygen level. Some folks get blood pressure cuffs at home, so you can take your blood pressure and share that with the team. There are different Bluetooth devices that can manage your blood sugar and share your glucose level wirelessly with your care team, or your Bluetooth enabled scale can share your weight. And so any smart device, it's very, very exciting. What do your providers use? They're using the same thing. They're using their phone at home. They're using their laptop, their webcam. There are also some peripherals so that they can actually hear heart, lung, and bowel sounds. So they're taking care of you at home, and someone in the hospital or the clinic is putting the stethoscope on you, and they can hear that. We also have roaming mobile carts. We call them teleports, and that can bring the patient bedside right to you if you're in a clinic or you're in an inpatient space, and allow you that face-to-face interaction. Now, what did this mean practically? So before COVID, we were doing less than 1% of our overall visits here at Hopkins via telemedicine. During the height, we were over 50% of our visits were in telemedicine. So we have completed over 400,000 visits with telemedicine. And this is an amazing just transformation. And the learning curve, for most of you, 88% of you who did a video visit, most likely you did not have one before the pandemic, and you had to learn right along with your provider how to use those telemedicine tools. So kudos to you, and kudos to our providers for using all the tools at their disposal. This is what it looked like here at Hopkins. You can see in early March, we're up in here, 16,000 visits. In here with this yellow is our in-person visits, with a drop off as soon as the pandemic hit. And then you can see us going up to over 50% and then leveling out. We're right now at 20 to 25%. Now, when you look at this whole thing, there are some visit types that are telemedicine neutral, right? Imaging, things like that, that cannot convert to telemedicine. So overall, to have over 50% go to telemedicine is extremely just impressive, and such a testament to our providers and patients. All right, I'm gonna stop here, and we're gonna introduce our panelists. And so you can hear from the providers what they're passionate about in telemedicine. And so our first provider here with us is Dr. Edward Healy. He is Chief of Cardiology at Suburban Hospital and a cardiologist, a practicing cardiologist. So let me stop sharing. All right, Kate.
Dr. Healy, you can start. I'm going to get your slides up on a second.
Sure. So we were not doing a lot of telemedicine in my practice prior to the pandemic. And just like what you saw on that prior slide, we became adept at doing it very quickly. So in my mind, a few things that have arisen with this are some pluses to telemedicine. And number one, expanding access. And that was so important during the pandemic. During the heyday of it, when people were having trouble getting into their doctor's offices because it wasn't safe, the offices were closed. And it also really, I found, can improve our efficiency. We lose a lot of time in the course of a day having patients come in and out of the office. And when we're doing a telemedicine visit, it can be much more seamless, and we can see more patients and expand access in that way. I think the most important thing for me, though, was it really encourages collaboration between the patients and physicians. We really have come to rely on our patients doing a lot of the work in a way, but home monitoring is so important in this. So we really encourage our patients to have home blood pressure cuffs and to be checking their blood pressure regularly, to take daily weights, to check a pulse oximeter to give us that reading. And in addition, there's a lot of tools that patients can use, and hopefully we'll touch on this later, to get things like rhythm strips or even multi-lead EKGs using smartphone apps. And that has really enabled us to get more out of these visits. So I think having the patients as a active participant and a partner in doing this really gets the most out of the visits for this. It promotes safety by enabling us to see patients without having to violate our social distancing. And in cardiology, there's actually a fair amount of evidence to support the use of telemedicine. There have been some great trials that happened years ago in heart failure patients discharged from the hospital and having telemedicine follow-up visits with nurses or nurse practitioners shown to reduce rehospitalization. And something that I've known about for a long time is remote monitoring of patients' devices like pacemakers and defibrillators. We used to have patients come into the office a few times a year to do that, but all of our patients now have home monitors that are essentially checking their heart rhythm devices every day, and that's been shown to actually improve hard outcomes as well, because we discover problems before the patient comes into the office or before they develop symptoms. There's a lot of questions or potential issues with telemedicine. There are still access limitations, and I think that'll sort of be addressed by some of the other speakers today and how we're trying to work around that. There are some people who just don't feel comfortable doing that. I don't think that necessarily is this audience, since so many people have participated, but for anyone who does have issues with that, hopefully will make you feel more at ease. I have questions about whether or not it'll last, and I think that that's more of a regulatory issue than anything else. The main limitation to the growth of telemedicine before the pandemic was regulations in terms of who you could do telemedicine with and how you could be reimbursed for it. And I wonder if we will be permitted to keep doing this the way we're doing it long term. And then lastly, although there is some great evidence in cardiology, I think we're going to need large-scale population evidence that this is an effective way to develop or deliver healthcare. And I think the studies will show that it is, but we do need that evidence basis. Thanks.
Great. Thank you, Dr. Healy. Our next presenter is Dr. Helen Hughes. She's the medical director for telemedicine at the Children's Center, and she's the assistant medical director for the Office of Telemedicine at the health system level and is a practicing pediatrician. Dr. Hughes?
Great. Thanks so much, Rebecca. So glad to be here today. So I've been interested in telemedicine for a while now, about 3 years. I serve patients in East Baltimore, many of whom have medical assistants, and through that was really interested in how we could improve access to care for children, which is the population I treat. But as Dr. Healy mentioned, there were so many regulatory barriers prior to COVID, and patients, at least children, needed to be in a place other than their home, like a school or a health department, to receive care via telemedicine. So in practice, it was very tough. Even though people believed it was a great way to improve access to care, it was tough to get programs started. So it was very wonderful for me to see, despite the pandemic being absolutely terrible, that the silver lining was that telemedicine became possible for so many families. And as a primary care pediatrician, we were doing lots of things via telemedicine, probably will not in the future, like child checkups, new baby visits, a lot of things that because people were so afraid of the virus, they really didn't want to come in. So I don't think, it definitely will not replace in-person care, but for a lot of things, depression follow-up, ADHD follow-up, asthma follow-up, our exam for many of those chronic condition and mental health concerns in primary care isn't necessarily adding a lot during those visits, and it's so much more convenient for the families to be in their homes. So I hope it won't go away. I hope much of it will last for many reasons. But we in the Office of Telemedicine are doing as much as we can to advocate for sustained changes that are really in the best interest of patients. So excited to talk more today.
That's great. Thank you, Dr. Hughes. Our next presenter is Dr. Laura Sander. She's the medical director for Sibley Primary Care and Community Outreach and Population Health at Sibley Memorial Hospital, and she is a practicing internist. Dr. Sander?
Yeah, good afternoon, everyone. I'm happy to be here as well and share my thoughts and experiences. I would echo the other co-hosts so far, and certainly Rebecca's data that shows that we've, through the pandemic, really accelerated our adoption of telemedicine in primary care, adult medicine. And this has been a welcome change, something that we've been trying to pilot actually dating to 2018, something you've also heard from the other presenters. So happily, we were able to really, you know, sort of quickly get patients on board with this technology, and providers as well. Through this process, we've all been learning so much, and we still are, as far as what is appropriate for telemedicine, what is not. And I think, as you heard Dr. Hughes say, there was a time where we were doing mostly everything by telemedicine, and now that's kind of being shaped and crafted as we understand the advantages and limitations, as well as some challenges on the patient's end. So we've learned a lot, and there's a lot more learning to do, certainly. I would also say, you know, I've welcomed the enhanced access that we've seen with telemedicine, in particular, where Sibley is located, kind of nestled into the northwest corner of DC, can easily take people a half a day to come out to clinic for their primary care visit. And telemedicine has really allowed us to connect with patients and avoid, you know, disrupting people's day-to-day lives. So that, you know, certainly is an advantage. Clinically, you know, what I've also enjoyed is that the telemedicine visit is focused on the history. And in that regard, we're spending a lot of time simply listening to patients, and often that really dictates the next steps of care and formulation of diagnosis. And so by definition, we're sort of doing more of that connection and active listening with patients. At the same time, as you've also heard, we're being creative about how we might be able to use physical exam maneuvers and techniques, you know, show me that rash, move your arm this way, sort of thing, to do assessments, and again, pushing the boundaries of what we're able to do by telemedicine. What I've also loved, sort of taking a step back, is having a nice window into patients' home environments. And so, you know, immediately visit this morning, a patient wasn't sure if she was taking a medication on her medication list. She grabbed her medicines, we went through, and it wasn't there. So I was able to reconcile and counsel her on, you know, that medication that she needed to pick up from the pharmacy, for instance. So that is a huge advantage. Whereas if that was an office visit, the patient would say, I don't know, they'd go home, they'd rummage through, they'd call me later, and, you know, it might take a day or so to clarify that. So it's a really nice advantage. I also have really enjoyed getting to know patients by observing their home environment, whether that be, you know, chips in the background or family photos on the wall. Oftentimes, some of those observations have sparked some conversation. So that's been a really positive change. And lastly, it's been wonderful using telemedicine to connect with caregivers and family members, which, you know, coming to join a patient at an office visit is a huge barrier for, you know, a working child of a patient of mine, for instance, who would again need to take like a half a day off of work to join the visit. So in that case, in real time, they can understand and bring to the table concerns that their loved one has, that then we can work through them together. So overall, it's been a series of rapid changes, and I would say patients and providers alike have certainly been up to the challenge.
Thank you so much, Dr. Sander. I think we're going to go straight into our questions. Dr. Brian Hasselfeld is on another panel, on another call, so he'll join us and jump right into the questions. So let's just get started. What are some of the pros and cons of telemedicine? Like, what's different? What do you like about it? Dr. Healy?
So I think something that Laura just mentioned is the time spent listening and talking. Mm-hmm. It really is it will promote that in a way that sometimes the office visit doesn't as much. You know, the person is, probably more comfortable because they're in their own setting. And when we lose all the sort of stuff that goes on around getting people into a room and maybe having them dress into a gown and that kind of thing, we gain time that we spend just talking about what kind of symptoms are you having, what kind of concerns do you have, what kind of side effects are you having to your medications. And I think to me that's been a major positive.
Yeah, I hear that from a lot of providers. Laura, do you want to add anything? Seems like you covered it.
Yeah, I think I shared all my highlights. Mm-hmm.
Yeah. We've heard from providers how wonderful it is, the pets and the kids in the home, and just seeing how relaxed people are. And if they get stressed, all their support system is right there, right? Their dog can come up and comfort them and calm them while they're talking about something that's so important to them. And so we've really heard lots of anecdotal stories about that.
I think on a personal level for me, on the other side of this, I actually finally got to attend like an appointment with one of my kids, which I haven't done in many years.
Mm-hmm.
I got to take my 13-year-old to a virtual dermatology appointment. And it was enlightening for me. Both I learned about what he actually says when he's in a doctor's office. And it also helped me to see what the patient experience is too, telemedicine visit.
Right, and have that. And that's a great lead into my next question. So dermatology seems like a great fit for telemedicine. So what other type of care is best suited to telemedicine? Dr. Hughes?
Thanks, Rebecca. I'm just going to share a slide to be giving a visual as I speak about this. But, as I mentioned a little bit in my introductory remarks, a lot of people think of the more talking specialties as well suited to telemedicine, particularly psychiatry, some sorts of primary care, psychology, and that is certainly true. And I think in the pandemic, we've seen some of those specialties actually enhance their care during the pandemic. Child psychiatry, for instance, has had higher show rates than they did prior to the pandemic, now that people are able to access them more conveniently. But during the pandemic, particularly during kind of the lockdown period, everyone was participating in telemedicine at Johns Hopkins. So this is all of our specialties essentially. And you can see, geriatric medicine, internal medicine are represented here, but also urology, ophthalmology, otolaryngology. And so even procedural based specialties that do rely a lot on in-person exam maneuvers and procedures still provided continuity of care to their patients during the pandemic through telemedicine. So I think as we look back, we'll learn a lot about what is possible, and that I think we're finding many providers feel like they were able to do more than they anticipated they would be through the video.
Yeah, it's been surprising and not surprising, but it's just been wonderful to see that uptake in adoption of the technology. I especially like it for oncology, just being able to be there for the patient during their whole course of treatment and not having them have to come in, but being there and being able to see them. Okay, so let's say I'm a patient, and what can I have at home to assist with this virtual visit? What's available out there to self-monitor? And I know Dr. Healy, you had talked about this, so let's hear from you, and then we'll hear from Dr. Hasselfeld.
Yeah, I think in cardiology, it's so important. Number one for me, the most basic one is always the home blood pressure cuff. And actually, I spent a lot of time during the last few weeks walking people through how to do it right. We have patients say, I can't make it work, and we'll go through and figure out what's not working for them. But that's very important for us. But we also have some, really advanced devices. There's a smartphone app available now that can do a multi-lead EKG. And when this all started, I think one of the things I heard from a lot of my partners is, the key to every cardiology visit is the EKG, right? How are we going to replicate that? And we've got a surprising number of patients who actually have been, bought into that, have been able to do it. They can send us like a 6-lead EKG, and even better, they can send it to us ahead of the visit so we can look at it beforehand and tell them what it shows. So that's been very helpful to us. And, also I'm a I'm a smartwatch wearer, and plenty of my patients have been able to do at least the 1 lead rhythm strips and send that to us, and also give us information on their heart rates over the course of the day. So there's a lot of wearables out there, a lot of apps that are available as well that can really contribute to how well the telemedicine visit goes.
Thank you, Dr. Healy. Yeah, it's so interesting. And I don't know how many folks on the line know, but your doctor can put in an order into your medical record to actually get your data straight from your smartwatch, can go up into Apple Health Kit and then go over into your medical record. So if you want to share your data with your doctor, please let them know. There's a way for that to happen. So I just want to take a moment and quickly introduce Dr. Brian Hasselfeld. He serves as the medical director for digital health and telemedicine at Johns Hopkins Health System, and is a practicing internist and pediatrician with Johns Hopkins physicians. Brian, welcome. Welcome. Do you have anything to add to how patients can prepare and what they should bring?
No, I mean, I think, a lot of folks jump right to what kind of neat technology could be in the home, which it can be really helpful and additive, but also can be costly and complex sometimes. I think from a non-technical side, there are a lot of benefits that as an internist and pediatrician, I think, see in different areas of the care continuum. For my adults, I've said this in different groups in the past, there's no longer any such thing as forgetting medications at home. There's no such thing as trying to need to describe to me, what the difficulty is with certain steps or how far it is from bed to bath. I can really truly understand the home environment and kind of engage with the patient where they live, which is fantastic. And similarly, Dr. Hughes and myself, when we see kids, understanding things that we might not ever otherwise pick up on, risk factors for asthma and allergies, the craziness of a home environment during a pandemic, and just kind of what that means for the social aspects of clinical care. So I think the technology is important, that being able to see patients in the home is equally clinically relevant in addition to just the technology.
Agree. Great points. So this sounds very attractive. So if you're a provider and you want your patients to participate in telemedicine, how do you let them know it's available? Dr. Sander, how do you share that with your patient?
Sure. So going back through the rapid changes we saw in March, we felt coming on the other side of that, we felt the need to share with patients that, hey, we're open, we want to see you to, whatever extent in the office as safely as we can, and also through telemedicine. So we sent out some massive communication in that regard. And I also think, frankly, word of mouth kind of quickly spread as well. And so that was helpful as patients called us for needs, and we addressed them either via telemedicine or potentially doing a telemedicine visit and saying, hey, I think you need to be seen in the office, which frankly, can happen. And I think in many cases this is quite appropriate, to get a quick evaluation by telemedicine and then do a follow-up visit. I think patients, as they started experiencing that and then telling their loved ones and community, word kind of spread that, certainly we're open and we can do this safely.
That's fantastic. Dr. Hughes, anything to add?
Similarly, for our practices in East Baltimore, we did have some kind of mass communications that went out through MyChart, which is our electronic patient portal. But in our clinic, only about half of our patients had MyChart at the time when the pandemic hit. So we did try some other things, Facebook, YouTube videos to get the word out. But also we did a lot of panel reviews. So we looked at our patients in Epic and tried to figure out who were our at-risk patients who had chronic diseases that needed to be followed closely, and just called them, had our social workers and others in our clinic reach out, and then scheduled them for video visits to check in, which I think was really successful, and people were so appreciative. I mean, I'm grateful that most of our patients are appreciative all the time, but I've never experienced quite so much appreciation as these pandemic video visit check-ins. And then I can just show a couple more resources from our website that if a provider is pointing a patient to the availability of video visits. I think this is the right time for me to go through this. I just wanted to show some of the resources that are available. So at our website URL, which I'll show here, is www.hopkinsmedicine.org/telemedicine/video visits. There's a lot of information to help patients know what to expect in general, and we're going to go through a little bit more in detail what a video visit is exactly like. But in that website, we have tips for a successful visit, including logging in early, tips for lighting and privacy, having your questions written down beforehand, and some information about recommended online browsers. There's a welcome letter that patients receive once they have a video visit scheduled in their electronic patient portal or MyChart account that walks them through the steps. And then we have a lot of great videos. So these are links, which if you went to our website, you could see to 3-minute YouTube videos that really have the basic steps of getting ready for a video visit. And also a 5-minute video about a little bit more what to expect about, what is virtual care and what can you expect as a patient. Some people are still confused, this is new, and that's to be expected. So when we were doing video well visits, for a 7-year-old, people often did not really know what that was going to be, even the providers. So we're all learning together. But I think our website has a lot of great resources that can help people know what to expect.
Yeah, that's great. Thank you, Dr. Hughes. And it's so interesting. Some of those resources are health system agnostic. And so if you're not part of Hopkins, if you're part of MedStar or Adventist or any of the other wonderful health systems in our region, they all, in my limited research that I've done, they all offer telemedicine. And so a lot of what we're talking about is across the board. And so reach out to your providers if you're interested in telemedicine and receiving services in this format. Now, people are interested, right? 88% of you have had video visits. I think the big question on everyone's mind is, what about the cost? Is this more expensive than seeing someone in person? Will my insurance cover video visits? What does that look like out there? Maybe Dr. Hasselfeld, you can weigh in first.
Sure. So, it's a difficult one to navigate a little bit because we definitely, the best answer there is that it can be very much dependent on your insurance plan, and we would absolutely encourage everyone to always check in with insurance plans ahead of new types of care to ensure that you understand the costs. And a lot of health systems are working really hard to ensure that we have better transparency on those costs. During the pandemic, we've been really fortunate as providers where none of us love to think about any of those aspects. We just want to get care to our patients. That there's a lot of flexibility underneath all sorts of types of insurance plans, inclusive of Medicaid, Medicare, Medicare Advantage, and most commercial plans, to make it easier and more similar to everything related to in-person care. And that includes co-payments and cost share and cost burden. So as providers, we feel very fortunate that insurance plans have made adjustments to make it easier for patients, but also that means easier for providers to connect with our patients without having to worry about all that. It is something that, unfortunately, we'll have to continue to watch as things change, as the pandemic and the public health emergency evolves. So it's complicated. As much as complicated as it is as a patient, it's also complicated as a provider to try to navigate all of those complexities sometimes.
Okay, so let's say as a patient, I've called my insurance, do you cover video visits? And they said, yep, you're covered, go on ahead, right? Now I'm thinking, what do I use for this? Do I use my phone, my tablet? So you as providers, you have to go through this thought process as well. So what do you use at home, and do you have any advice for patients? Dr. Healy?
So I think my advice for patients is to test what you have ahead of time as well. I did one telemedicine visit from home as a patient. Also, I saw my primary care provider through JHCP that way. I think to test in your audio and visual ahead of time is important if you can. Some of them are also browser specific, and hopefully you've gotten that information ahead of time and you're loaded correctly for that. I think from a tech standpoint, those are sort of the most important things on the patient side.
Mm-hmm. That's true. Dr. Hughes, would you add anything?
If you really using whatever device you're most comfortable with is probably going to work the best. So I like to use a laptop or a desktop computer. My mom, who had a video visit recently, likes to use her iPad. So I think trying to work with whatever's most comfortable for you is best. And then also around privacy. So I have young children in my house and there's a pandemic and they're in the house. So I try to lock myself away so that I know my patients will have privacy. I will have a space. So similarly, you know, if you're having a visit and you're going to be discussing things you wouldn't want someone else in your house to know about, making sure you have a private space as well. We have had patients launch video visits from the car in a drive-through of a fast food restaurant, and that's quite difficult to deliver care when there's, you know, not a private setting and other things going on. So kind of treating it as seriously as you would treat an in-person visit.
Mm-hmm. That's great advice. Now, speaking of children in the background, let's talk about family during these video visits. We have some folks on the line who are village members, and they, before the pandemic, would bring a medical note taker with them, or a volunteer, or let's say I want to bring my mom or my daughter with me. It sounds like I can do that from some of your previous conversations. How do you feel about that as a provider? Dr. Hasselfeld?
I think anyone that our patient wants to be in the visit is always welcome, and it's really, I apologize, it was a little bit late, but it was on another kind of virtual webinar, and a lot of panelists were sharing stories of their own care. I think you know, more and more we live in different states than our family members, and to be able to bring our family members into our care remotely has been great, and it's great for providers to have that additional touch point as well. We all forget things quickly right after something's told to us. To be able to ensure everyone's on the same page as far as understanding is always so helpful. It's really helpful in pediatrics, where multi-working families, you know, where different parents or family members may be in different settings, maybe less so during a pandemic, but it's really helpful just to be able to bring everyone together. And I think we all obviously would welcome that in any visit where the patient thinks it's permitted or, you know, or desired.
Mm-hmm. Dr. Sander, would you add anything?
Yeah, I absolutely agree. And would just add that, you know, as we've heard, 88% of you all have successfully completed a video visit. I would challenge you all, you know, outside of your family network, to tap into that community network and help those 13% plus access this sort of service. You know, the regulations are a bit of a question mark, but my belief is that telemedicine will be here to stay. And as the technology evolves, hopefully it will just be easier for people to get connected to care, you know, with one or two clicks, hopefully as easy as we can make it for patients and for providers alike. And I really am concerned about the folks that potentially would be left behind because they're not able to access the technology. So I would put out a challenge to everybody who has successfully completed a visit to talk with not only family members, but also friends in the community to see who maybe hasn't and why, and help get them connected to care this way.
Yeah,
Well, that's a great point.
It's great, Laura. Yeah, we've continued to try to make the technology easier and easier. It's still not super easy, but we're continuing to work on it, and you know, trying to make it as much like what, you know, my own family members are spread out across multiple states and across multiple ages, from teens to 90s, and we all connect through FaceTime, right? And I think because, you know, interacting over video, especially now, is becoming more and more common, and we're trying to make it that easy. So I think you know, that we still have some work to do, but trying to overcome some of that initial fear of engaging in technology is important. And you know, I think there's no harm in reaching out. Like our, you know, to think about what you do when you come into an in-person visit. Hopefully you get there a little bit early, but you got to do paperwork and interact with the front desk, and it takes a long time to get all that done. take some of that time ahead of your virtual visit and reach out to the practices and ask for help, because I do think that there is help available to try to figure out some of the ways to successfully get ready for a visit. Certainly in some of our own practices, that is true.
Mm-hmm. Thank you, Dr. Hasselfeld. And that is a great lead-in. For 12% of you who haven't had a video visit, we're going to do a live demo of one so you can see what it's like. Now, interesting point that Dr. Hasselfeld brought up is filling out that paperwork and doing all those things pre-visit. Just because you have a video visit, that stuff doesn't go away. And so we want to show you how you can do that digitally. And so here to walk us through, we have Steve Clapper. He's an EPIC project lead for telemedicine. And we have Cindy Diaz, who's our telemedicine development manager. Steve is going to be the patient, and Cindy is going to be Dr. Diaz. And so you can see how a patient will connect. Now, just to set the stage, we're going to be going in through our patient portal, and this is called MyChart. Depending on your health system, you may have a different patient portal to enter for telemedicine. And we're going to show you how you access it from the portal, and if you don't have it, how you access it. All right, so Steve, take it away.
Thanks, Rebecca. Okay, so as Rebecca said, we are at our MyChart patient portal. Now to get here, you can either go to hopkinsmedicine.org and click right on this little button here and select MyChart, or you can just simply Google MyChart Hopkins and you'll find a link immediately. So today I'm going to be logging in as our Becky patient. Becky has an appointment, a video visit scheduled today at 3:10. And Becky knows this. She has received some notifications that an appointment had been scheduled, instructions telling her to sign into MyChart 15 minutes before her appointment and then start the video visit. So and then she was also able to add an appointment directly from MyChart into her personal calendar. So I'm going to go into MyChart as Becky. And we're signed into MyChart. Now, a few things I want to call out. First, the item here at the top of our list says begin your 3:10 video visit appointment. And now, most other patient portals are designed the same way, where they'll have a link immediately when you log in, they'll let you know that's where to access your video visit. Before we do that, I want to call out a couple things. One is on our quick link section, there is a button here that says test your video. As Dr. Healy alluded to, it's really important for patients to test their video. They've run into some issues, delays in their appointment because they hadn't tested their computer or their device ahead of time. If I click it, this will go to the test page for our portal, for our video platform, which is Cisco WebEx, which is a browser-based video platform. For us, we don't require any apps either on a computer or a mobile device to be downloaded and installed. It will work directly on your computer's web browser. The only browser that's not supported for us is Internet Explorer. All other browsers such as Firefox, Chrome, Safari, and Edge are supported. However, we ask that you do install the latest versions. You need to install the latest version of Edge and in some cases Chrome for video to work. So once we've completed that, we can just go right up here to begin your video visit appointment. And if you hadn't seen MyChart before, just as an aside, there are a list of to-do items for the patient. This is a test patient, of course, so you may see a few more things than you would see in your own MyChart account. I'm going to click right on begin your 3:10 video visit appointment. Now this is our appointment details for our video visit. We can see our instructions for our visit that tell us, for example, do not come to the office for this appointment, which is important for patients to know. And then some instructions on video visits, such as completing a test. Now, one thing that we require for our video visits here is e-check-in. And I'll go ahead and complete it. Now you notice it actually says right here, you must complete e-check-in before joining the video visit. And this is required in order to be able to start the video visit from MyChart. So I'll go ahead and click on e-check-in. So e-check-in is sort of a pre-check-in workflow. This is where the patient can complete tasks that would normally be completed at the front desk or with an MA, a medical assistant. We see some items such as personal information and insurance. So we'll go through this workflow, these steps, and see what this looks like. So the first thing we're asked here is to verify our personal information, just make sure we have the same address, phone number, etc. Everything's correct here, so I'm just going to click on this information is correct and click next. Insurance, we're able to update our insurance directly in MyChart. So if our insurance policy had changed, we can actually add in insurance cards right here. Now, this step is easier to do in a mobile app, in an iPhone or an Android, because you can take the picture of the cards right with the phone and then scan it and then upload it directly from the phone as well. If you do it from a PC, you most likely have to use a camera and then get that file to the computer to upload. So a couple extra steps if you do it through a PC or a Mac. So I'm just going to say that everything is correct and fill out a couple items here. And then click next. Now, this is an important step I wanted to call out. This is our signed document step for e-signature. So normally when you would be at the front desk, you would be asked to sign certain documents. Obviously, that's not going to happen with a video visit since you're not at the office. So here's where we can sign these documents remotely. I have two documents that are due to be signed, the telemedicine acknowledgement and the outpatient agreement form. Our telemedicine acknowledgement form is required for video visits. It's actually required by the state of Maryland, and it's valid for 1 year. Our outpatient agreement form is valid for 6 months. So you would see this form appear every 6 months. Let's click on review and sign and see what this looks like. The telemedicine acknowledgement form, it's not very long. It's fairly quick to read, and we'll go ahead and just agree to it. And at the end here, I am required to enter in my password currently, just to verify that I am actually signing this form. And I'll do the same thing with our outpatient agreement form. This is a longer form. We'll go through this one fairly quickly. And I have a couple items I need to authorize, or at least make a selection. And say that I am the patient, and no need to, since I'm not a representative, I don't need to fill any of these. I'll just click the one box and enter in my password again. Now both forms are signed, so I will click next. Now, the next 3 steps in our e-check-in are related to your medical information in your patient chart. This is where you would see your med list, your allergies, an allergy list, and your health issues that we have on file for you. For medications, you would see the list here. As we can see, this patient has 2 medications, and we can select to either add a medication or remove a medication. Perhaps we're no longer taking Lipitor, and we can choose to remove that. And then when that is done, that actually does not directly update your med list at Hopkins. What it does is it sends a notification to your chart. So your provider or any other clinicians working in your chart can see that you've you've notified us that you're no longer taking a medication or you're taking a new one. So I'll say this information is correct. And same thing with allergies. This patient has 1 allergy. We're going to say this is correct. And with health issues as well. We're going to select this information is correct, no changes needed. We'll click submit. So our e-check-in is done. E-check-in can actually be completed starting at 7 days before the appointment. So even though I completed this on the day of the appointment, it can be done far in advance, and we encourage folks to do that if that's appropriate. So now we have our start video visit button. This becomes available starting at 30 minutes before the appointment. And we are asked by our providers to join usually around 15 minutes before the appointment. Before we click that, I wanted to call out one feature here that we have. It says show video link. We have some patients who would like friends or family members or other caregivers to join them in the visit. So they may not want to give them full access to their medical record in MyChart, but they just want to give them the video link. That way they can join them for the visit. And it's very similar to a patient bringing someone with them to the office. So what we've allowed patients to do, or enable patients to do, is click on this show video link button where they can see the long link that we have here, click copy. And then we can then you can easily paste that into an email or do whatever you want with it to then send it off to a friend or family member. In our case, though, we're just going to go ahead and click Start Video Visit because it's time to meet with our provider. So I'll go ahead and do that now. And now this is loading up our Cisco WebEx video platform. And it takes me directly into our provider's waiting room. And I'll stay here usually for a few minutes until your provider or someone in the office is ready to meet with you. And sometimes we'll have someone in the office come to meet with you as a greeter who will ask you a few questions and let you know your provider will be meeting with you soon. So here I have my provider joining with me. Hi, Dr. Cindy. So the video will look a little choppy for me because I'm doing it through Zoom. But this is where we would now have our video visit. So fairly easy to start our video visit and connect with our provider.
So, yeah, what would happen if I don't have that whole MyChart piece, or I've forgotten my MyChart password? Because this is probably the #1 issue that we come across. Yes, I have a MyChart, but I can't find the password. Can you reset me, right? So what happens in that situation? Can I still join?
It's a great question. Yes, we've actually enabled a feature, the ability for providers in the clinical office to send the video link directly to patients over a text message. So as long as you have an iPhone or an Android, then your provider can text you that link, and then you can click right on that link and join the video.
Great. So if I can't get into MyChart or I don't have it, the provider's office can call me and facilitate that, or I can call them and they can send me a text.
Yes, and if necessary, your provider's office can get that link to you in other ways as well. If you don't have an iPhone or Android, there may be some other
options. They could send it in an email. Okay, wonderful. Well, thank you so much. I know you guys have a 3 o'clock meeting, but I want to thank both Steve and Cindy for their time and for showing us what a video visit looks from the patient viewpoint.
All right, thank you.
Hi, guys. Okay, so I just want to let the audience know that attached to your invite is a one-stop or one-pager for telemedicine, and a lot of the links to get ready for a video visit are right on there, and that would be really easy to access in your email, and so you can test those links. Okay, so is telemedicine here to stay? What will it look like next year, 5 years, in 20 years? And what should we do now to utilize the best of telemedicine to prepare for this future? What advice would you give patients? Let's start with Dr. Hughes.
You know, I don't think any of us know, but I can say what I hope. I think COVID in 1 year will have led to pretty significant changes from before, but I think we won't necessarily have all of the waivers in place that we had during the peak of the pandemic. So I think we'll be able to use it either with certain populations or certain conditions, and we will we'll continue to learn as we deliver care to make sure we're doing it in a way that makes sense for patients and is evidence-based. So I think a lot of the next year will continue to focus on video visits and also incorporating remote patient monitoring. I think in the 5 to 10 to 20 year is where a lot of the technologies, the wearables, the data, using data that we can gather from patients in their homes to improve care using technology and artificial intelligence so that things are easier both for patients and providers to use the information. But ultimately, I don't think we will replace in-person care. 3 of us here are primary care doctors, and sometimes I hear people saying like, well, can't we just have Alexa and people can just ask a question like, what was my baby's rash? And then they'll get the answer. Like, medicine is still about relationships and having a person that you trust. And so that is, in my opinion, never going to go away. And the technology is really about bringing people together. And so I hope that in 20 years, we'll be thankful we have the technology so we can spend more time with our patients and have better relationships with them.
Mm-hmm. So Dr. Healy, as a specialist, what does the future look like to you?
I think the technology isn't going to go away. You know, there's going to be a lot of issues about who's going to pay for it and how much they're going to pay. And I think all of us know that in the end, that really drives what happens in medicine, right? We can't do work that we're not paid for. And that was really the primary issue with telemedicine previously. So I think if it's going to last, I think it's going to be because the consumer or the patient demands it. And I think if people have positive experiences with telemedicine now, then it's more likely to last into the future. From the perspective of a cardiologist, I think that what we're going to see is incorporating more and more data that the patients bring to us. And that is somehow, hopefully, incorporated into a report or that we can read easily. And, you know, I think right now we're too dependent on patients sort of sending us things when they get it. And I think we'll need some system through our health records that really makes it easy for us to look at and interpret quickly.
So Dr. Sander, your thoughts?
Yeah, I agree with all of that. I do think in the immediate period, we're going to be refining telemedicine as a tool that we use as physicians, again, understanding, you know, which conditions, which situations, which patients it's most appropriate for as we're all learning that piece. You know, I do believe that it is here to stay. And I do think patients and physicians will be demanding it alike. And hopefully that will push those in the regulatory positions to kind of align the legislation to what the needs are of the public, really. And yeah, I agree. Over the next many years, we will see flourishing of a lot of different devices and whatnot. And we'll, you know, I'll be looking to technologies for physicians to help filter some of that information, because otherwise we could potentially be quickly overwhelmed with all of this and how to interpret and whatnot. So yeah, lots of exciting things certainly in store from my perspective, and I think it's here to stay.
Oh, that's wonderful. So Dr. Hasselfeld, as medical director for digital health, how do you see the future rolling out?
Well, I hope it has a strong future. My job might be dependent on it. But no, I mean, I think I agree with all my fellow clinicians on the line here that we're one of the last big areas of our daily life that is so inconvenient. It takes so much work to get to a doctor's appointment, whether it's time and travel, navigating a complex hospital building, paying $20 for parking in downtown Baltimore, DC. It just takes a lot of time, and we've made everything else in our lives like pretty convenient. And but medicine is also so intimate and private and personal, as Dr. Hughes was referencing. And so you need to find the right balance between those things, but really trying to bring all of our care out to where patients, you know, are. That's the tagline that we all like to use, you know, meet our patients and where they are. And I think that that's the ultimate goal. And I think a lot of care will ultimately transition to something that is easier and convenient, and will become more and more clinically feasible. Right now, what's clinically feasible is what fits onto what we're doing now, a video conversation. And then we add heart tracing, and then we add a blood pressure. And over time, we add more and more things that, you know, more and more things will become clinically appropriate at a distance and over technology. And I think we'll continue to see that shift.
Well, I'm really excited to be part of it. I think both as a patient and an administrator, as a consumer and a provider, it's really, really an exciting space to be in. Let's take a few minutes. We have about 25 minutes left. Let's take a few minutes and hear from our participants. I'm going to go through some of the questions. Some of them may be pointed to a specific person, or you can chime in. So Kathy asks, are there significant differences in charges for asynchronous and synchronous services? Differences in insurance coverage for both of these? How does Medicare fit into this model of coverage? Anybody want to weigh in?
Yeah. So I'm not sure if we defined all those terms, but we did. Okay.
Yeah.
So telemedicine, where you're submitting history and questions and complaints through a formatted platform and waiting for a response versus kind of interacting directly with the clinician. The coverage landscape of those two things, like coverage with lots of things, is highly variable. And not all systems are set up to both deliver care through those asynchronous modalities, much less figure out how to navigate the insurance landscape for those modalities. So I think the easiest answer is to say that they are different. Medicare covers both, but just because something is covered doesn't mean something is offered. And so I think that all of us are going to grow together, insurance and providers and patients, and understanding what types of technology are ultimately going to be the things that make the most sense for patients and providers to do. And we're going to all have to work together to figure out how to navigate that. So the short answer is they're different. They may be covered by different payers. For Medicare, they are, but not all providers offer both things.
Great.
And I would just add, outside of the billing and payment issues, we do field a lot of asynchronous messages or my chart messages in our world. And I would just sort of share that many patients who express new concerns that way, we often say, you know what, we should do a visit. And sometimes that's video, sometimes that's office. Again, these are the learnings that we're doing as we're figuring out what's the most appropriate and timely care for patients. But asynchronous communication can be great from my perspective to follow up a recent visit you might have had, a clarifying question, something like that, or a concern that maybe you've had before, but new concerns, ideally you'd have carved out time with your provider to work through.
Mm-hmm. And I think it's so interesting that you could start in one mode, right? You could start asynchronously and then clinically be prompted to move into a synchronous mode. And the same thing, you could start with a video visit and the provider could say, I'd be more comfortable seeing you. Let's get you in here, right? And so things can shift both ways. And I love that fluidity all around the patient to make sure they're being cared for in the best way possible. Okay, we have another attendee who has asked, I thought there had been an agreement that Medicare plus Medigap would pay for telemedicine appointments, but I've been billed for some of the amount of a regular visit to my primary care physician. How come? And I think that would go back to Brian's answer that each benefit package is going to be a little different. And some are going to be covered, some are going to require co-pays, and some won't. And I think you're going to have to go back to your insurance plan for that one. Would the folks on the line agree? Our panelists? About right?
Yeah, and I would just add, if it's covered, that doesn't mean that you don't have any costs associated with it. As Rebecca said, you might have your typical copay or co-insurance or whatever amount that might be. And it is a complicated world to navigate all of these different aspects of payers and insurance models, for sure.
Yeah, and I think regardless of the modality, your deductible is still in play. So there's so many different things happening there. All right, Catherine has a question. She has a question about remote monitoring devices. Many new devices like biometric devices, over-the-counter monitors, etc., are using VR, virtual reality, and AI in the home. How do caregivers and patients choose devices? Do insurances, particularly Medicare, pay for the devices? Are there any downsides? All right, maybe Dr. Healy, you want to speak to this, and then perhaps Dr. Hasselfeld?
Well, I'll speak to about coverage. It's almost certainly not going to be there. It's very unusual for any of those things to be paid for by your insurance. And part of that is that a lot of them are not clinically tested, right? So I have patients, and I love the Apple Watch. I run EKGs on myself all the time because I'm a cardiac electrophysiologist. But if you read what Apple says about it, they said it's not for clinical use. And it is not for use for people who have atrial fibrillation. Even their atrial fibrillation monitor says that. So really, I think that those are things that people are going to have to, adopt on their own. In terms of recommending things, I am very hesitant to recommend a specific product to anybody. I'll talk to my patients about what is available, what I know about. About the only time that I recommend a specific product is if they want to know a blood pressure monitor. I tell them to get the Omron 3, but that's about it.
That's a great answer, because Kathy actually asked, she's gone through 3 different over-the-counter blood pressure monitors. And so I think, Kathy, your answer is an Omron 3. All right, does anyone know, we have a question, are there more sensitive wearable devices being developed for seniors specifically? Any thoughts?
I'm not aware of any that are senior specific. I can tell you that I haven't seen they be any less reliable in seniors than in other people. The monitors that I've seen, especially the EKG devices, seem to work just as well regardless of the age group.
Mm-hmm. That's great. And we also have a second part to the question. Can I get someone to walk me through how to use my blood pressure cuff without charging me a teleoffice fee? And so I think call your physician's office. They're used to these kind of tech calls, and just ask them directly.
One thing I'll add on, we do get a lot of technical questions about devices, and what I'll tell people is whatever you bought almost certainly comes with a helpline. And that should really be your first call. If you bought something and you don't know how to make it work, take a look at the insert that was in there, and there's almost certainly a line that you can call that will be product specific.
That's great advice.
Yeah, I agree. I would also add that sometimes it can be useful if there's a question of the accuracy of the device to have patients come in with their home blood pressure monitor, for instance, and in the context of a visit, check the patient's home device, and then we use our own, which are calibrated and standardized and accurate. So and then that use that opportunity as well to review blood pressure monitoring technique.
Well, that's an excellent point. Now we are hearing, we have a patient question here saying, I consider myself high risk. I don't want to go anywhere. I don't feel comfortable coming into the doctor's office, but I don't want to waste resources, right? I don't want to use doctor services unless there's an immediate or urgent problem, or unless someone reaches out to us. Should we be delaying care in this time? What are folks' thoughts about that? Dr. Hughes?
We generally would recommend you do not delay your routine care. So there was a period in March and April where all of us were struggling to figure out, both on the clinician side and the patient side, how we can make sure we're doing everything safely. But we have a lot of procedures in place, and all the clinics have had to go through a state certification process to make sure they have measures in place to protect people for in-person care. So with that, plus the addition of telemedicine, physicians and providers have a lot of capacity to deliver the same volume of care that they were delivering pre-pandemic. And because of the backlog of cases of March and April, we are kind of struggling to make sure we get everyone in. So if everyone were to delay their care for one entire year, we'd have a lot of people who needed more follow-up. And then also, unfortunately, we are seeing people delay kind of checking up on their usual issues with their primary care doctor or their specialist. And then unfortunately, we are seeing some worse exacerbations of chronic conditions needing to present to the emergency department because people haven't necessarily been able to kind of keep on top of things with the help of their care team. So we'd recommend continuing to receive your care in whatever way you feel is safest, whatever way you and your provider feel is safest.
Mm-hmm. So don't delay. Excellent. We have an off-topic question. Dr. Healy, what's your favorite baseball team?
So that's from the Washington Nationals last season, actually.
Excellent.
Not getting to any games this year, of course, but I'm still basking in the glow.
That's awesome. So your screensaver there in basking in the glow brings us to privacy. What types of things do we need to look at in terms of privacy, both your privacy as providers and patients' privacy?
I mean, I think we, all want our health information to be private. So as an institution, all of the platforms that we use for clinical care have gone through security review, have legal agreements in place between us and that video vendor that obligate them to protect information to really strict standards. However, during the pandemic, lots of governmental agencies have said that if you and the patient together want to decide that you want to use a different platform to connect, if you want to pick up your phone and use FaceTime, and you and the patient, you the provider and you the patient, both say, look, I really would just like to interact with you on this platform right now, then that's something that you can choose together, so long as everyone's really aware of that, informed about that. That's not something that we recommend as our primary pathway. All of our primary pathways for doing telemedicine are underneath those video options that are subject to those security reviews and restrictions and legal agreements and all that type of stuff. But it is a flexibility that more folks can choose during the pandemic if you really want to. We just encourage you, wherever you seek care, to make sure you're informed about that risk, if that's a pathway you choose to select. And then, as Rebecca was referencing, our environments are no longer contained anymore. So we're not contained together inside of one exam room that feels very private. And so we ask our providers